Hello guys, a very good evening. Hope I'm audible and visible. I hope so. It's swelling for me. I hope you don't have that problem. Okay, so let's start. Let's start today's class of MCQs on immunology, right? So in the Unacademy app, what we have done is for the past few week and before we have had 5 classes on the general pathology, 2 on neoplasia, and hopefully with this and this next class we'll be completing the entire general pathology. Today we're going to discuss a few things about immunology. I'm sure immunology must have been an overlap for you in both microbiology as well as pathology, and I'm sure you must be much more thorough than other topics, right? Good evening, Ian. And if you're attending the classes regularly, do attend the tests as well. Tests are actually the thing which is going to give you an understanding of how well your preparation is. It's useful to assess your reading, whether you're in the right path or not. Please do that as well. Fine. Yes, Ayush, immunology is interesting. At the same time, it's a bit more factual on that side, so might not be much forthcoming for undergraduate at least. Fine. So if you're a plus subscriber, you'll get all these benefits, and you can get into Unacademy app. Under my profile, you'll have free classes which you are doing this week onwards. We are doing a couple of these onwards. We are having the chapter wise revision. If you're free from 7 to 8 p.m. daily, please do attend that. Fine. And if you're a subscriber, you can enroll to any of these batches. If you're not a subscriber, if you wish to subscribe, you can subscribe using any code, or if you don't have a code, you can use PathoCups. Fine. Okay, so let's start. The routine is the same. Unfortunately, I cannot create a poll here. Sure, Ashraf, Aurora, I will definitely try to give it to you. I don't have image-based discussion on YouTube everywhere. It will be mostly on the Unacademy app. I'll definitely compile the link and put it forward in the groups. Fine. Okay. So what I'll do is I'll display a question. I'll go mute myself for 30 seconds, 45 seconds. Then I want you guys to comment the answer. There is no poll here. When there is no poll, I know that at least 50% of you are inhibited in commenting the answer, thinking that you might go wrong. It's fine if you go wrong. That's not a problem at all. Even if you feel that someone will come and pick you up since you answer something wrong, there's an option of retracting your comment on YouTube live. Please feel free to do that. Fine. So let's go with the first question. Read through the question and go comment the answer. I'll mute myself for 30 seconds. Okay, SN has started with B. Let's see. Anyone else wants to add to it? Some. Okay, C, Rahul, Sakdeep, and Rahul has gone with C. Yin has gone with C. Anyone else wants to add? There are many of you online here. Please do comment on the answer. It's fine if you're wrong. Okay, D, C. Great. Fine, we'll read through the question and see what could be the probable answer. It's a 28-year-old person suffering from pulmonary sarcoidosis. Flow cytometry analysis shows that isolated from the alveoli as well as the lung interstitium had lots of T helper cells, Th1 subtype, right? So the question is basically on the Th1 subtype. If you remember the helper cells actually bind to the antigen presenting cells, and it can differentiate into 3 different subtypes. Can anyone name what are the 3 different subtypes of T helper cells? We have Th1 response, we have Th2, and we have one more thing which is Th17, right? So we have Th1, Th2 as well as Th17 response. Actually, based on what the stimulus is, based on what the antigen presenting cell is going to present to the T cells, it differs into different subgroups, right? So when it differs to my Th1 subtype, right? When it differs to my Th1 subtype, what happens is these Th1 CD4 cells will secrete your interferon gamma and your interleukin 2. Actually, this interferon gamma and interleukin 2, what they do is they kind of convert the macrophage into activated macrophages. The CD4 Th cells, whatever subgroup they are going to anyway going to be involved in the B cell or in your macrophage activation, right? So this is going to activate macrophages. If you remember, if it activated macrophages, what type of macrophage activation, what will be the type of activated macrophages in response to Th1 subtype, M1 or M2 subtype. You have two types of macrophage activation as well, which causes M1. The same CD4 cell can also secrete your interleukin 13, interleukin 4. This causes your M2 activation, right? So my CD4 T helper cells in the Th1 pathway itself have multiple options. In sarcoidosis, like you guys said, it's predominantly your interleukin 2 and interferon gamma secretion, which automatically initiates a chronic inflammation, and like Saktib said, that it's going to cause your epithelioid cells and it will finally end up in the granuloma formation. Fine. For a Th2 response, what do you think will be the examples for T helper cell type 2 response? Like which disease? Like sarcoidosis is Th1. What will be there in Th2? Can anyone say that in Th2? Most of your allergic response will be Th2, right? Perfect. Anything apart from allergies? Type 4 hypersensitivity will be Th2 or Th1? Type 4 hypersensitivity will be Th1 and Th17, right? It will not be Th2. Th2 is predominantly your allergic response, the type 1 hypersensitivity reaction, anaphylaxis, allergy, eosinophil activation, everything will be Th1 response, right? Since you took in type 4 hypersensitivity, actually in type 4 hypersensitivity, I'll have either Th1 or my Th17. Th2 will not be involved here, right? Now I'm going to give you different examples of type 1 hypersensitivity. Tell me which is Th1 or Th17, right? Just a basic difference. Your multiple sclerosis, Th1 or Th17? The commonest method of activation. In most of them, both will be activated, but the commonest one, multiple sclerosis, mostly Th1. Your contact dermatitis, Th1 or Th17? Contact dermatitis is also Th1, right? Your tuberculosis is Th1. When I say tuberculosis, leprosy also comes into that. All your tuberculin reaction, lepra reaction, everything comes into that, right? Psoriasis, your inflammatory bowel disease, Th1 or Th17? Inflammatory bowel disease as well as psoriasis is predominantly your Th17 response. See, that is also type 4 hypersensitivity, which comes under your Th17 response. So whenever Th17 response comes, you'll have both neutrophils plus lymphocytes. See, this is how the cytokines will attract them. Both neutrophils as well as lymphocytes will be seen both in psoriasis as well as inflammatory bowel disease. That corroborates your finding of your Monroe's microabscess that I shared in the Telegram group today. Also your cryptapsis cryptitis, where you'll have both neutrophils as well as lymphocytes in your inflammatory bowel disease as well. Fine. Okay. We go to the next question. It's a very simple one. I'll be asking many leading questions in this. So look at the question and do comment the answer. I want everyone to comment the answer. When there is no poll, you guys inhibit yourselves and don't comment the answer. Don't restrict yourselves. Please comment on the answer. Okay, it started. Sankadeep has started with B. Kushi is B again. It's good. Easy ones will attract more comments for sure, but I want everyone to get involved here. Fine. It's a very simple, right? So most of them are going for B. A pathologist examines a renal biopsy. 45-year-old man with nephrotic syndrome requests a congruent sign to confirm the nature of the deposit. And if it's a positive test, what does it mean? So it's an indirectly question asking a congruent positive material is going to be amyloid, right? Amyloidosis will definitely be congruent positive, right? Perfect. Extracellular hyaline proteinaceous deposit, everything fits into amyloid, but if it's congruent positive, it will definitely be amyloid, right? Few leading questions regarding amyloidosis. I want everyone to answer here and listen carefully and answer. When I'm doing a congruent stain and I'm looking at the slide in a light microscopy, what will be the color of amyloid? Apple green birefringence or pink in color? You've done a congruent, you're looking at that in a light microscopy. What will be the color of amyloid? Apple green birefringence or pink in color? It will be pink in color, right? It will not be apple green birefringence. Apple green birefringence will be seen on which microscopy? On a light microscopy, amyloid will still be pink in color in spite of staining with Congo red, right? Your apple green birefringence will be only on a polarized light. Only when I use a polarized microscopy, yes, to be specific, like Rahul said, it will be salmon pink. On a polarized microscopy, you will have your classical apple green birefringence. Okay, it will not be on a light microscopy, only on a, not a fluorescent, on a polarized microscopy. In fluorescence is totally different. In a fluorescent microscopy, also I get the green color, but I use a dye there. Here, there's no green color dye. In spite of that, I'll have this polarized microscopy, apple green birefringence. Fine. How does a Congo red create this apple green birefringence? The mechanism of Congo red creating apple green birefringence. To understand that, we have to know about amyloid in general. When an amyloid gets deposited, it's definitely a protein, right? A misfolded protein. Is it an alpha helix or a beta pleated sheet? Amyloids. Amyloids are perfect non-branching fibrils of beta pleated sheets, right? This is what you must have read. Let's assume amyloid fibers are like this. These are my amyloid fibers, right? Tiny amyloid fibers. It's non-branching and it's perfectly beta pleated sheets. Long, slender sheets, fine? So when you have a tiny amyloid fibers like this, if I shine light through these fibers, let's assume the fiber is very thin like this, I cannot see a background, right? Because the light will go, it will not create a shadow. That's why amyloid doesn't have any color or any property on a light microscopy. So, but when you do a Congo red stain, Congo red binds like this. The Congo red actually binds to the fibers. When something binds to the fibers, perfect, it binds to the fibers, and if I'm going to throw light into it, it gets reflected. That reflected light will be captured by a polarizer. That reflected light cannot be captured by a normal light microscopy. This polarizer captures the reflected light and gives a different wavelength, different color, and apple green birefringence. Congo red binds to these non-branching fibrils and gives the apple green birefringence. That can also come in an MCQ, fine. A few things which are always in confusion. We'll try to settle the confusion today. The best biopsy to diagnose or investigate a case of systemic amyloidosis. Rectal fat pad or rectal biopsy or an abdomen fat pad. What will be the best? I'm not going to sensitive or specific. I'm just asking which of these two will be the best. Rectal biopsy or an abdomen fat pad? The answer is always abdomen fat pad. Rectal biopsy is not the best. It's not used in most of the conditions. See, diagnosis of amyloid is very, very simple. If I'm going to have a renal amyloidosis, I take a renal biopsy and see what's happening. If the amyloid is systemic, I don't know which organ is getting involved. If it's a heart, I cannot take a heart. I'm going to take an easy accessible site. The reason why I prefer abdomen fat pad or rectal biopsies, both of them have abundance of blood vessels. Keep in mind, amyloid always deposits surrounding the blood vessels. It always deposits surrounding the blood vessels. Abdomen fat also has lots of blood vessels. Rectum also has lots of blood vessels. You know, because you must have read about your hemorrhoids, submucosal vessels, right? Lots of them, right? The preferential side is abdomen for simple reason. It's easy to take. Even if it fails first time, you can take it the second time also. Rectum is difficult to take. It will bleed. You'll have lots of complications. So rectum biopsy is not preferred. Ultimately, is the ease for the doctor as well as the patient. Abdomen fat pad is the best test to diagnose your systemic case of amyloidosis. Fine. Devraj, it's not so rare. I would say that if you see, it is mostly focused as subspecialty. If you're a nephrologist, you will definitely see quite a few cases of amyloidosis. If you're a general physician, you might not see much. The reason why amyloidosis is increasing in condition is, let's take for example the arthritis groups, the autoimmune diseases. Over the period of years, the autoimmune inflammatory pathogenesis is increasing or reducing. Definitely the incidence is increasing, right? So once it increases, tuberculosis or my infection I can treat. Rheumatoid arthritis, osteoarthritis, or any arthritis or autoimmune groups, I cannot treat. I can reduce the severity, that's all. So the long-term increases, whenever the long-term inflammation state increases, the chance of AA amyloidosis is increasing over the period of time. In addition to that, the neoplasm of multiple myeloma is also contributing that, right? So it's not very rare. You'll definitely come across, when if you're doing a general medicine PG, you'll definitely come across at least 10-20 cases per year easily. Fine, in a very good volume center. Fine. Okay, come to the next question. I'll mute myself for 30 seconds. Again, this is a simple one. I want you to comment. Options. Okay, Sankdeep, Kushi, Ian. Okay, most of you went for IgE, right? It's a very simple question. Within minutes of a beasting, it's just IgE antibodies, right? So if I have to evaluate the serum of this patient, this question I discussed in the plus class today. If you have to evaluate the serum of the same patient, right, same type 1 hypersensitivity, which enzyme levels will be elevated? Or do you have any biochemical enzyme marker for a type 1 hypersensitivity? Same patient, same scenario. Any enzyme which will tell me, okay, there is a type 1 hypersensitivity going on, apart from your immunoglobulin, which tells me about the pathogenesis. Recollect the pathogenesis. You'll have an perfect, right? Serum levels of tryptase will be elevated. Fine. Because tryptase is a sign of mast cell activation, right? So mast cell will definitely be activated in case of a type 1 hypersensitivity. So tryptase level will be elevated. That's like a serum marker. IgE antibodies also will be elevated. That can also be taken care of. Fine. So if you have a different question in a different scenario with the same history, you might have a tiny variation. Tryptase is a mast cell marker. Do remember that. Fine. Okay. I'm not going to discuss much about this. I'm sure you know about everything about type 1 allergy anaphylaxis. Fine. Go to the next question. Read the question carefully and give the answer. I'll mute myself for some time. Answers? Anyone? Okay, SNS started with C. Anyone else? Okay, B. Okay, B is the predominant one. D. Okay, fine. Okay, let's assume that if I have, instead of option A, if there is neutrophils, will there be any change in that answer, or still you will stick with lymphocytes? Because predominant of you are going with either monocytes, macrophages, or your lymphocytes. If option A is neutrophil and it's an acute cellular rejection, will there be any change? No, right? Still it's going to be B, right? The acute nature of the disease here doesn't change it, right? Here it is not neutrophils, it's always lymphocytes. The thing what is important for me is the cellular rejection. Whenever cellular rejection comes into place, it has to be lymphocytes only. This might be the cell which can cause the damage. Like I said, let's assume that a T lymphocyte is coming inside in the acute cellular rejection, which is going to get activated in the Th1 pathway. Will it recruit more macrophages for destruction? It will, right? So macrophage will definitely be there as an effector tissue. But what is causing the damage is T cells only, right? Both acute as well as in chronic rejection, the only thing what I'm going to have is lymphocytes. What differentiate what lymphocyte is it? It's either acute cellular rejection based on T lymphocyte or an acute humoral rejection based on my B cells, right? If it's an antibody, it's a humoral rejection. It's a T cell, it's a cellular rejection, right? So here, what I will have a difficulty is I need to differentiate whether it's an acute cellular rejection or an acute humoral rejection, because the treatment is different. If it's an acute cellular rejection, I'm having a B cell, I'm having a plasma cell, I'm having an antibody. The treatment might be kind of a plasmapheresis. You do a plasmapheresis, filter out all the antibody destroying my kidney, I can kind of reduce the rejection, right? If it's a T cell, I have to go more on the base of immunosuppression. I cannot do plasmapheresis in that instance, right? So I am in a position to differentiate whether it's a T cell mediated cellular rejection or a B cell mediated cellular rejection. Okay, there's a marker for that, and that was asked in your question as well. Can any one of you tell me what marker is used for an humoral rejection? Acute or chronic? If it's a humoral rejection, that's a marker useful for it. What marker is that? And I want you to tell the base of the marker as well. Any marker for acute humoral rejection? Perfect. It was C4D, right? This is asked once. Do remember that. Perfect. C4D, that too, it should be only in the blood vessels, not in the tubules. It should be in the peritubular capillaries. If it's a renal rejection, it should be in the peritubular capillaries. It should be in the blood vessels. In the blood vessels, if C4D are positive, then it's suggestive of an acute humoral rejection. The treatment is based on this. That's why this becomes more important in a transplant setting. It came in your exam as well. Fine. C4D in the capillaries. The reason why I'm going to use C4D is when it's in B lymphocyte producing an immunoglobulin, definitely complement will be activated as an effector pathway. As opposed to T cells, it will be monocyte macrophage system. So I can assay the complement saying that okay, C4D is deposited here, which means complement is activated, which means antibody was there and it's in B cell mediated rejection, right? This is a very, very good marker to suggest a humoral rejection, right? Both acute and chronic humoral rejection will have that, fine. An acute cellular rejection is divided into two groups based on the structure which is getting destroyed. I can either call it tubulitis, tubulointerstitial damage, or a vascular damage. Generally, an cellular humoral rejection will always be a vascular damage only, fine. So when the vasculitis is there are two possibilities, T and B. That time a C4D helps you to differentiate both of them, fine. Okay, we'll go to the next question. It's a simple one. There are quite a few people here online. I want everyone to comment on this at least. It's a very, very simple question. 30 seconds, I'll go mute myself. Okay, quite a few of you have gone with D. Why didn't you go with C? That's my first question. Why didn't you go with C? None of you been taking care of this HIV virus. It's Kaposi sarcoma. It is D, right? Yeah, it is definitely D. C is not the answer. I just expect at least one person to go with C. Great, you didn't go. Guys didn't fall for a trap. The question which is asking is about the tumor cells. It's not in general. In general, definitely the patient in circulation will have the HIV genome. That's not a point of the question at all. Here, it is the tumor cells. If you look at the question, the molecular analysis of the spindle-shaped cells found in the skin lesion. Like you guys said, there's a classical case of its Kaposi sarcoma. Kaposi sarcoma are neoplastic transformation of an endothelial cell, which is due to your HHV8 human Kaposiform virus only. It is not due to HIV virus, right? It's definitely due to your human Kaposiform virus. Fine. Again, a few leading questions to it. Which part of the body Kaposi sarcomas are very common? There are few places where Kaposi sarcomas are extremely common. Which part of the body is that? Kaposi sarcomas are extremely common. Skin and subcutaneous tissue. It's very common. Most of the images what you must have seen must also be skin lesions, right? Skin, subcutaneous tissue. Internal organs in GIT is a bit more common. Fine, that's one. Kaposi sarcomas, due to HHV8 inflammation, actually there is a pathogenesis which is newly added in your Robbins. Previously we didn't know how Kaposi was the HHV8 was causing sarcoma. Now it is said that the HHV8 virus, via two ways it can cause it. One is inflammation related. It will cause inflammation, which will increase the VEGF production. When VEGF production is increased, obviously endothelium will start proliferating. At the same time, the Kaposi sarcoma virus has an homologue of cyclin D1. The homologue of cyclin D1 is there in the sarcoma virus. Cyclin D1 is obviously a proto-oncogene. So when the virus provides me cyclin D1, it's kind of overexpressed. That increases the more proliferation, right? More proliferation with the help of VEGF due to inflammation, and also cyclin D1, a viral homologue gene which causes Kaposi sarcomas. Fine. There's a new pathogenesis added. So this makes sure that even in Kaposi sarcoma, the genome of HHV8 integrates with the human genome and produces more amount of cyclin D1, right? In your hepatitis virus, it is not integrating. We saw them in the neoplasia chapter. Kaposi sarcoma integrates and causes the change. Fine. Okay, can any one of you tell me markers for Kaposi sarcoma? Any one immunohistochemistry marker for Kaposi sarcoma? I'm sure you know multiple. I just want one. Kaposi sarcoma markers: CD31, CD34, factor 8. All of them are Kaposi sarcoma markers. Fine. 34, yes, for sure, but I will prefer 31 or factor 8 because 34 is a stem cell marker which can be seen in multiple things. Fine. So 31 and factor 8 are more important than it. Again, it's very easy to remember 31. You cannot forget CD31 in a vascular lesion. If you remember inflammation chapter, what is the other name for CD31? What is the other name for CD31 in the inflammation chapter? Have you read them as PCAM? You must have read them as PCAM, right? So can I say that PCAM is a molecule which is going to help a person in diabetes? Yes. Right? If something helps in diabetes, can I say that this PCAM should be present in every blood vessel in the body? Because every blood vessel can undergo inflammation, can have diabetes, right? So in other words, if there's an endothelium, that must be PCAM. So tumor which comes from the endothelium, will they also express PCAM? They have to. A tumor which comes from endothelium is your Kaposi sarcoma. They have to express PCAM, that is CD31, which has to be positive. Fine. It's a simple extrapolation of fact which you already know. I'm just extrapolating it and seeing in the tumor. Fine. Kaposi sarcoma is benign or malignant? Kaposi is benign or malignant? That's again a very simple question. Simple questions are very tricky for us. Benign or malignant? Kaposi is neither benign nor malignant. Kaposi is an intermediate grade neoplasm. Fine. Though the word sarcoma is there, Kaposi is not malignant. It's an intermediate grade neoplasm. Benign vascular tumors are your hemangiomas, capillary and cavernous. Malignant vascular tumors are your angiosarcoma and hemangiopericytoma, right? Kaposi is an intermediate grade neoplasm. It is not benign, not malignant. Do remember it. Kaposi sarcoma is not malignant, it's intermediate. Which means why we have kept an intermediate group is, if I take care of your HIV virus, if I give heart therapy and reduce the virulence of HIV, reduce the copies of HIV, when the immunity increases, Kaposis might regress. A cancer will not regress when I take care of the infection, right? If I eradicate EBV, doesn't mean that DLBCL should resolve. It will not. But here, when I take care of the virus, when the HHV8 reduces in load, the Kaposi sarcoma regresses certain amount. That's why we keep them as intermediate neoplasm. We don't call them malignant. Fine. Okay. Next question. Read through the question. I'll mute myself for 15 to 30 seconds. Comment on the answers. Prathume Kumar, I'm not able to understand your question. Can CMP, I think a little bit of typo. Can you rephrase it? Okay, answers? If not the option, can you go ahead with the diagnosis first? Okay, Naveen has gone with C. Anyone wants to add? B, D, B. Okay, tell me the diagnosis first. Then we'll definitely come to an answer. Answer is not difficult if we know the diagnosis. Okay, it's a 1-year-old boy with repeated pyogenic infection, Staphylohaemophilus for 6 months. Test for T cell function, granulocyte function, complement function, everything is normal, right? So my T cells, neutrophils, complements, everything are normal, perfect. So the only person who is affected here is the B cell because my immunoglobulin is 50, the normal is 500, it's very less, right? And flow cytometry reveals absence of heavy chain in the blood lymphocytes, which means the B cells, I'm not having the heavy chain on the surface, fine? Heavy chain sense immunoglobulin chain, that's all. Mu is M, right? Because if you remember, any normal B lymphocytes on their surface will have two immunoglobulins, which is M and D. Here mu stands for IgM, fine? So the IgM on the surface of a B cell is absent on a flow cytometry. So can I say that all the B cells, what is there in the circulation is a very immature cell? It's not matured at all. For the maturation, I need the Bruton tyrosine kinase, like you guys said that. So these mature cells are not there. It's very immature cells, right? So the diagnosis here is perfect. Bruton's agammaglobulinemia, right? So if it's a Bruton's agammaglobulinemia, now look at the options and tell which is the most probable fit. If there is no B cell development at all, will there be lymphoid tissue be normal? It will not be, right? Because follicles require good amount of mature B cells. I won't have that. Follicular hyperplasia can never happen because every lymph node is a lymphoid organ, is a mature lymphoid organ. Lymphocytes will not be there at all. T cells is not a problem in this disease. I am not going to affect about that as well. The thing is my germinal centers. It's a B cell disorder where there is no mature B cell at all. So there can never be a germinal center in this patient. Actually, the lymph nodes here will become atretic. It will be completely gone. There will be no plasma cells in this patient. If all these are true, what do you think will happen to Peyer's patches? The lymph node reduces in size. There will be nil plasma cells in these patients. What do you think will happen to Peyer's patches in these patients? Peyer's patches also will become atrophy, right? You won't see Peyer's patches because that's also B cell predominant, mature B cells, everything will be gone, right? So it's Bruton's agammaglobulinemia and option D is the correct answer, fine. So to questions like this, the first clue was to diagnose the disease. For any immunodeficiency disorder, keep in mind very simple rule. Bacterial B cell, fungal viral T cell. If it's neutrophils involved, like your chronic granulomatosis or something, you'll have in the clue that it's either your neutrophil bactericidal activity is affected, something of that sort, fine. Sometimes both B and T can be involved. You know the combination of SCID and CVID, where both of them can be involved as well. First, try to bifurcate whether it's a pure B cell defect, combined B and T, or pure T. If you have done that, then a subtle clue will be there. A 1-year-old boy involved. Whenever I have this information, I'm going to think of an X-linked recessive inheritance. If only men are affected, right? So my inheritance again comes in clue. It will help me that, okay, what type of inheritance is. I can easily narrow down to my diagnosis, fine. Okay. Next question. This is a simple question. I'll not take much time. I want everyone to comment at least for this question. I know this is simple. Answers? It's a very simple one, right? It's a classical case of an SLE, arthralgia, low-grade fever, high titers of antibodies, your double standard DNA, Smith antigen, everything. It's a classical case of SLE. SLE has to be a type 3 hypersensitivity, fine? Right? Good. So when you guys can answer for a simple question, please do answer for a difficult question as well. That increases your confidence. It's not going to be helpful for me. It will definitely be helpful for you. Fine. So we already have discussed about why SLE will have your malar and discoid rash, right? We'll try to explain other organ system involved in SLE. Fine. There are few characteristic organ involved in SLE. One is your skin. We know because of the hairpin-shaped blood vessel it gets involved. The second one is your renal, kidney. Again, kidney also has lots of hairpin-shaped blood vessel, it can get involved. The other two organs, see, I have ignored this for convenience. blood will automatically be the commonest organ involved because it will have circulating immune complex. So definitely RBCs, autoimmune hemolytic anemia will happen, right? Perfect. Now instead of saying it as heart, I'm going to call them as serosal involvement. Serositis is very, very common SLE, be it pericardium, be it pleura, or be it arthritis. Like in this question also you had arthralgia, right? So serosal involvement and joints involvement are very common in SLE. It has a particular reason why these organ systems are getting involved. These two is due to the vascularity. Again, blood is directly there, fine. Why serosa is getting involved and why arthralgia is very important is both serosa, be it pleura or pericardium or your synovial fluid, how are they formed? What is the mechanism of formation of pleural fluid, pericardial fluid, or synovial fluid? Am I right in saying that they are formed via ultrafiltration? Yes, it's filtration, right? So I have a perfectly normal blood vessel here, be it synovium or the pleura and pericardia. So the force acts and pulls the fluid out of them. It causes ultrafiltration and which produces the fluid. So whenever I'm saying there's an ultrafiltration process happening in a blood vessel, will there be turbulence in the blood vessel? Definitely there'll be turbulence, right? So when there's turbulence in the blood vessel, will the circulating immune complex deposit on the wall of the vessel? It will, because normally my circulating immune complex will be in a perfect laminar flow like this. When the filtration happens, automatically it becomes turbulent and will get deposited in the wall. Once it gets deposited in the wall, it will cause vasculitis and it will cause all the problem, fine. Okay, that's the reason serosal involvement and arthritis is also common, right? Blood is undoubtedly common. These are the common organs of SLE involvement, fine. Libman-Sachs endocarditis. The reason I didn't want to comment on Libman-Sachs endocarditis or cardiac damage per se is it's more of an hyped thing, right? It's more for an MCQ scenario. When you take SLE, the incidence of Libman-Sachs endocarditis is very less compared to skin or your serosa or your kidney or your blood involvement. They do have, but I'm not saying that it is very common, right? These are the commonest tissues or organs getting affected. Rest are a bit rare. It's SLE. It can involve any structure from head to foot, right? The common ones are these. I'm sure you know the mnemonic of Soprain MD. So I hope you will not have a difficulty in other organ involvements. Fine, great. For the next question, read the question carefully and tell the answer. Again, it's a very simple one. Answer. Good. You guys should open up for simple ones. At the same time, you would answer a little bit difficult ones as well, right? So it's a classical case of Manto. Manto is which type of hypersensitivity? It's definitely an type 4 hypersensitivity, and type 4 hypersensitivity will definitely involve your T cells and macrophages. Naveen, see, there are multiple theories why autoimmune disorder are more common in women. Fine. There is no foolproof evidence saying that, okay, this is the reason why autoimmune disorders are more common in women. One of the crudest theory, which I personally believe, is the hygiene hypothesis. I'm sure that all of you here will accept that undoubtedly women are more hygienic than men. Yes. If you're a guy, sorry, that's how it is true. Right? One population washes hand before eating and after eating. One population washes hand only after eating, right? So women are a bit more hygienic than men, because hygiene hypothesis is something which is the current belief of autoimmune disorder. You don't get exposed to much of the organisms when you grow up, when your immune system develops. What happens is my immune system is going to target my own self-antigen and getting destroyed. This is one of the hypotheses which is said that women in general are more predisposed to it. At the same time, a scientific basis that estrogen kinds of has some immunomodulatory effect, because when a woman in her uterus is going to take care of a baby, or is going to take care of a guy's sperm. Can I say that a baby is undoubtedly foreign for a woman? Yes, it is undoubtedly foreign, right? But still, none of the mother rejects the baby, except in few scenarios, right? Which means women intrinsically, the hormones has lots of immunomodulatory effects. It's going to modulate my immune system at multiple places. It has to suppress the immune system for the survival of the baby. Once it does that, it's kind of stopping my normal process, right? So definitely there's a risk it can go away and become abnormal as well, right? These are two theories which have said that the reason why women has more chance of autoimmune disorder compared to men, right? Again, it's not foolproof, they are just theories. Okay, fine. We'll go to the next question. Read the question and let's see. I'll mute myself for 30 seconds. Answers? Most welcome, Naveen. Okay, Ian has started with B. Anyone else wants to add? B, A, okay, Japna has gone with B as well. Okay, what is the primary diagnosis here? So once we know the primary diagnosis, answer is definitely easy, right? A person who is having an AML, disease and allogenic bone marrow transplantation, 2 weeks later she develops jaundice, maculopapular rash as well as profuse diarrhea, which means I'm having an involvement of liver, bile tract, skin and GIT. I'm sure now you must have known the diagnosis: liver involvement, skin involvement and GVHD, right? Obviously it's going to be GVHD, your GIT involvement, right? So graft versus host disease is the diagnosis in this patient, happening almost 3 weeks later, right? If it's 3 weeks, it is acute GVHD or chronic GVHD. Ian has answered that already, which is an acute GVHD, right? So what is the cutoff day or week I have to call it an acute versus chronic GVHD? When will you call something as an acute versus chronic? It's 100 days, right? So anything less than 100 days, I'm going to call it an acute GVHD. Anything more than 100 days, we'll go into call it a chronic GVHD. Fine. Whatever be the cause, whether it be an acute or a chronic GVHD, the thing which is going to cause GVHD is the donor's T cells, right? So the attack of the host epithelium by the donor's T lymphocytes can be CD3 or CD8, right? So donor's T cell, which is going to destroy the host, who is an immunosuppressed host in this condition for any bone marrow transplant. That's when you're going to end up in GVHD, fine. Both in acute as well as in chronic GVHD, the same 3 organs are affected. The only difference is in a chronic GVHD, like any other chronic inflammation, instead of having more of an destruction, I'll have more of scarring of the skin and scarring of the liver. There will be more scarring because of more fibrosis and more involvement will be there. Perfect. So GVHD happens, like Ian said, when I have an immunocompetent donor and an immunosuppressed host, right? I'm sure that's what you wanted to type in. It's fine. So tell me, so in which all situations you can expect GVHD? One is obviously a bone marrow transplant. Any other examples where you can expect GVHD? A graft versus host disease. Can you expect GVHD in a renal transplant? You cannot have a GVHD in renal transplant. In which all transplants you'll have GVHD? One obviously is bone marrow. Kidney is unlikely. Hematopoietic stem cell transplant, yes, for sure. You can have them in splenic transplant, though it is rare, you can have them. In liver transplant, you can have them. See, renal is a bit unlikely for the simple reason that renal doesn't have any proliferating lymphoid tissue. Spleen and liver, they do have proliferating lymphoid tissue, right? Last, you can have in you blood transfusion as well. Sometimes even blood transfusion can trigger GVHD. Again, though it's an unlikely, very rare scenario, it can. Liver can. See, liver and spleen can I say that during a fetal stage or an embryo stage, they were taking care of hematopoiesis? Yes. So they're taking care of hematopoiesis during a fetal or an embryo stage. So definitely they do have a little bit of hematopoietic quality, which means they have proliferating lymphoid tissue present in them. So all these will have proliferating lymphoid tissue. That's why I call it an immunocompetent graft to an immunosuppressed host, and definitely it can cause an GVHD. There are possibilities. Undoubtedly, the common one is your bone marrow transplantation. Fine. Okay. For the next question, look at the question, read the question, look at the image, come to a diagnosis, and then tell the answer. I'll mute myself for 30-45 seconds. I want you guys to comment. It's okay if you make a mistake. Any answers? Anyone? Okay, John has gone with A. Chapna has gone with A as well. Great. Samrat. A, good. So diagnosis, like Samrat said, my diagnosis here is systemic sclerosis, right? Limited or diffuse? Is it systemic sclerosis or a limited problem? It is a diffuse systemic sclerosis, right? Okay, it has to be a diffuse systemic sclerosis because lung involvement is there. Sorry, lung involvement is there. There is pulmonary hypertension and cor pulmonale, so it has to be a diffuse, right? It cannot be a limited one with lung involvement. When the underlying organs are involved, it has to be a diffuse systemic sclerosis. And what you are seeing in the microscopy is more interesting, and that's what I want. What are you seeing in the microscopy? What is there in the microscopy? This is a skin biopsy. In the skin biopsy in the microscopy, what are you seeing? What are you observing? Sclerosis, fibrosis, yes. Can you guys name the finding or name the disease? You must have read about this disease in your dermatology. It's definitely full of collagen fibrosis, fully sclerosed tissues there. But what is more interesting and what is more important for me here is there are no adnexal structures. You don't see a sweat gland, you don't see a sebaceous gland, nothing is there, right? It's completely gone. There are no adnexal structures. If you remember, have you heard about this in your dermatology? Morphia? Perfect. So this is how morphia microscopy looks, right? So if you have any question on dermatology in regards with morphia, microscopy looks like this. It's completely collagenized, no adnexal tissue. That's the reason you must have also read in your dermatology, scleroderma patients will have a very beautiful shiny skin, no wrinkles in the skin, no pimples, nothing will be there because it's completely gone. It's only collagen. It looks perfectly flushed up, right? So that's how morphia looks. Okay, adnexal in the meaning, when I have a hair follicle, and let's assume this is a hair follicle, whatever glands are in adjacent to the hair follicle, they are called as adnexal structures. Fine. Your sweat gland, your sebaceous gland, all of them are called as adnexal structures. Adnexa means nearby. Just an easier way to get this term, uterine adnexa, you have the ovaries. Adnexa is nearby. Fine. Okay, so hair follicle adnexa or these glands. I hope it's clear there, Braj. Okay, read this question. I am sure you'll be able to identify the diagnosis, but it's a factual based question. Let's see if you can pick up the fact. I'll mute myself for 30 seconds. Diagnosis. Tell me the diagnosis and tell me the answer. Diagnosis is very simple here, right? Like Yin said that the diagnosis is a classical case of an Wiskott-Aldrich syndrome, right? Good, Chetna. It's an easy case of an Wiskott-Aldrich syndrome. A 2-year boy is eczema, thrombocytopenia. Brother has the same abnormality, X-linked inheritance, and none of the sisters are affected. That's also perfect, right? Everything fits with your Wiskott-Aldrich syndrome. In Wiskott-Aldrich syndrome, there will be a defect in the recognition of polysaccharide antigen. Fine, it's a polysaccharide antigen defect will be there. We will maybe read the in-depth pathogenesis of Wiskott-Aldrich sometime. Wiskott-Aldrich syndrome, there will be definitely a defective antibody response to a polysaccharide antigen, right? Just to remember this as a fact for now. We'll see why sometimes later. Fine, okay, great. Okay, read the question and the answer. It's an easy question. We just now discussed about the disease, so I'll mute myself for a few seconds. You will definitely come up with the answer. Answer, diagnosis and answer. Samrat Yun has gone with A. Good, Japna. A. Again, diagnosis. Can anyone tell me the diagnosis? Okay, answer is right. So I presume that you must have arrived at the diagnosis, right? The patient has various complaints. It's classical case of Crest syndrome, right? Small painful lumps in the skin and his fingers. What are these? What is the first symptom target? That must have been your calcinosis cutis, right? And painful episodes in the fingers and toes which turn blue, Raynaud's phenomenon. And you have the heartburn because of your esophageal dysmotility. Sclerotactile is there, the claw-like appearance, and telangiectasia, right? You have all the 5 components of Crest in this patient, which is nothing but a limited systemic sclerosis, right? It's a classical case of a limited systemic sclerosis, and you have antibodies and against your centromeric proteins, right? I have explained this before. Let's see if any one of you can answer this. We call them a limited systemic sclerosis. So skin manifestations, I'm completely okay with it. Blood vessels also, I'm completely okay with it. Esophagus is an organ, right? It's an internal organ. Esophagus should ideally not be involved in limited systemic sclerosis, right? But still, your esophageal dysmotility is a component of Crest syndrome. Have you ever thought of that? Esophagus is an internal organ. When I say that lung will be involved only in diffuse cases, esophagus should also be involved only in diffuse cases, right? Ideally, right? But esophagus is still involved in a limited systemic sclerosis. Why? I have told this explanation before. I am not sure if you remember that. Perfect, Samrat, right? Esophagus lacks serosa. Good. So when esophagus lacks serosa, serosa is where I am going to have the fat. For any intra-abdominal organ or any internal organ, the fat is the cushion. Since esophagus lacks serosa, it lacks the serosal fat, it lacks the cushion. So when I eat, there is peristalsis. When there's peristalsis, definitely there is an outward force, inward force, outward force, inverse force, but no fat for me to have the cushion effect. So there will be tiny micro damages happening. In a systemic sclerosis, whenever micro damages happen, normally itself I'll have fibrosis, here I'll have more fibrosis, right? Because of the anatomy of the esophagus, since it lacks the serosa and the subserosal fat, esophagus will be involved even in a limited case of systemic sclerosis, fine? This is the one entire part of GIT, the only place where I'm going to have no subserosal fat and continuous peristalsis is esophagus, fine? That's the reason esophagus gets involved, okay? Great. Next question. Read the question, understand the question, and give the answer. It's a simple one only. Answer? First tell me the diagnosis, then we'll go to the answer. Okay, starts with C. Afsha. Tebraj with D, C again. What is the diagnosis here? A. JIPMER. What is the diagnosis? It's a 7-month-old kid. Perfect, right? 7-month-old kid. Okay. Multiple bouts of otitis media, sinusitis, oral candidiasis, and multiple viral infection. Unlikely for an IgA syndrome to have these, right? IgA deficiency, isolated IgA deficiency are generally very rarely symptomatic. Most of them are asymptomatic, right? It's a classical case of an SCID. It's a severe combined immunodeficiency. The 7-month itself should have given you the hint, fine? The question is, cessation of the recurrent infections after successful bone marrow transplant is due to which of the following, right? I'm giving a bone marrow transplantation for a patient developing the having an SCID, which means I'm totally changing the hematopoietic precursor, which means the donor's lymphoid tissue are improving. When the donor's lymphoid tissue improve, there'll be more amount of new B cells and T cells which are not defective. When the B cells and T lymphocytes which are not defective increases, automatically all the recurrent infections will be taken care of, right? The way a bone marrow transplant works in SCID is, in SCID there's a defect in the stem cell that's been removed and I'm going to give new stem cell, right? So the maturation of the donor lymphoid progenitor cells, that's a stem cell transplant, which is in graft, that if it gives new B and T lymphocytes which are functional, automatically the infections reduces, fine? Okay. Next question. Read the question, look at the image, and then come to the answer. Good memory, Ian. It's a 26-year-old, joint pain, past 2 years, rashes in the bridge of cheek and everything. My diagnosis is already sorted in the first 2 letters. It's SLE, right? And if you see the image, there's an damage of my I'll come to it there, Braj. There's damage of the epidermal basal layer, and obviously which is we have an evidence for that. There's an immune mediated damage based on the immunofluorescence image, fine? Okay. The question is, which of the following which of the following will be a long-term complication of your SLE? That's all. See, blindness is not the main complication, and SLE and Raynaud's doesn't have any issues or no exposure to cold environments. Arthralgia will be there, undoubtedly, but it will not cause a joint deformity. I'll have arthritis, I'll have arthralgia. It's not like rheumatoid or osteoarthritis, you'll have SLE-induced deformity. If it is there, you are the first persons to know the different types of deformity, right? You never know any deformity related to SLE, right? And obviously, chronic renal failure will definitely be there. It is ultimately the end stage of SLE, renal failure, requiring transplant. Almost many people who suffer from SLE, the first organ to get knocked off is kidney, and it's very difficult to survive without a renal transplant, fine? So it's a classical case of a lupus with a long-term effect should be a chronic renal failure. Okay, perfect. We will end today's class. We have seen quite a few questions on your immunology perspective. From Monday onwards, I'll give you a timetable for the next week. Couple of days, keep it free, relax, read other subjects. Definitely come back and we'll have the same Monday, Tuesday and Thursday. We'll do it till April middle. I wanted to complete the first time, and maybe in the May middle we'll complete the second revision as well. Fine. If you have any doubts, do let me know. Sure, Japna, I'll explain both the images, and Debraj, I'll answer your question as well. Just give me a second. See, in SLE, what happens here is, in skin, here what happens, the basal cell gets destroyed in the skin. These are my basal layer of epithelium. There's a basal vacuolar degeneration. Okay. So there's a basal vacuolar degeneration which has caused the rashes in the skin, fine, because of the destruction, fine. So these basal cells are getting destroyed. See, basal macular degeneration can be there in many skin condition. Right from a lichen planus, it can be seen in many skin condition. But lichen planus will not be involved, will not have an immunoglobulin deposition. The second image, what you see here is an immunofluorescence image. The immunofluorescence image will be positive only in an autoimmune disorder. Fine. If you see here, this is my epidermis, because if it is negative, it will be completely black, and this is my dermis. Anjali, the time will be from 7 to 8 p.m. It will be in the Unacademy app. You can download that and you can follow me in the profile. Fine. So the dermo-epidermal junction is where you have the green line, which means I am having an exact green line, which is deposition of the immunoglobulin, the complex here. The immune complex getting deposited here, that causes destruction. So in an immune-mediated destruction, I can rule out other possibilities. Like lichen, as I said, will not have an immune-mediated destruction, right? So that's why this picture fits into an immune-mediated skin destruction, and clinically I'm having a malar and discoid rash, which means it corroborates to your SLE finding. Fine, Japna? Okay, Debraj, coming to your question, you have read the topics, but how to correlate in an MCQ, right? I know that you're in second year. You might find a bit of a difficulty because you're in second year, that's all, right? When you start going to your clinics in the morning session of second year, or when you go into clinics in your third year, there's a case scenario. You will take histories, you'll get used to it. Over the period of time, in 6 months to a year, you automatically will become more proficient in these, right? So as of now, if you're a second year student or if you're in a first year, I want you to make sure the concepts are clear. That's enough. In the first and second year are basic sciences. I don't expect you to diagnose cases in first, second year. Once you have the knowledge of basic sciences, you will start taking history. That time you will definitely correlate. The part you might feel difficult is it's a very huge history. I'm not able to link two things. You will definitely start linking when you start seeing patients, when you start taking histories. Just wait for 6 more months. Once you finish your second year, third year and final year, you will start seeing more and more patients. There, your knowledge is going to be extremely useful. Your understanding will definitely compound. Fine. Okay. Hope that answers your query. Okay. So see you guys. See you again by Monday in the Unacademy app at 7 p.m. That will be the classes for you. We'll continue with whatever topics is left. Fine. Thank you for your time. Have a good night. Sweet dreams. Bye-bye.